Well, one of the unique opportunities we offer for members of ICOS is to apply for certification as a center of excellence. And one of the requirements for certification is that each program identify quality improvement projects that they have developed for their institution. These are programs that contribute in some way to increased efficiency in operations or especially improvements in patient care. And we were so impressed by the quality of these programs that we want to share them with our community. And one of the ways we're doing that is by way of a series of podcast recordings highlighting some of the gold standard programs. So today, it's a real pleasure to welcome Dr. Carrie Lennemam, who leads the Cardio-Oncology program at the University of Alabama in Birmingham. Carrie, thanks for being with us and thanks for sharing this program with us.
Great. Well, thank you, Stephen, and thank you to the ICOS. I did want to speak a little bit about our cardio-oncology quality improvement project, which is leveraging a system called Tempus Next for timely referral to cardio-oncology clinics to our team. Because as you know, in many healthcare systems, patients are being seen in a big healthcare system and sometimes can get lost. So this was to help generate appropriate cardio-onc referrals in our system. Again, it's been designed as a clinical decision support tool to help provide sort of gentle notifications that will go into the EMR to our oncology team to help encourage appropriate cardio-onc referrals when abnormal echoes are obtained and unique parameters are fulfilled that are thought to be abnormal and should be maybe considered for a cardio-onc referral. So again, a little bit about Tempus Next. We've been working with this company. It's a care pathway that uses artificial intelligence to help us find abnormalities in the EMR on certain specific patients on parameters that we set. And it can identify gaps where that patient is maybe not appropriately being seen. Like we'll talk about our oncology patients that have certain abnormal echo parameters that are specified, and the software can see that they're not referred to us in cardio-onc or not seeing a cardiologist in our system. It will then notify the oncology team saying these parameters have been identified and we don't see any current appointments in the system for a cardiologist or the cardio-onc team specifically, and can help gently nudge the oncologist to say, consider a referral. And it can track things longitudinally over time, which is great. So it's not even one snapshot. It can be looking at the next 6 months prior or even the 6 months before that. So it has a longitudinal perspective of being able to see when patients are being seen within our healthcare system. So again, our Tempus Next, again, like I said, it uses artificial intelligence and machine learning to actually identify oncology patients who have had an echo ordered in our system. Where we'll then have certain parameters that we'll go over that are flagged as abnormal or thought to be clinically significant for oncology patients. And then, like I said, can identify if patients are not already scheduled to see a cardiologist or a cardio-onc team. And then we'll send out a electronic notification in our EMR, and I'll show an example of that. And this just kind of helps prevent people falling through the cracks. Which is great. So what our current algorithm is designed as is it wanted to look for anyone who has significant LV dilation, significant parameters, significant RV dilation, significant signs of pulmonary hypertension, as we see here. If patients have a moderate or severe pericardial effusion, have significant diastolic dysfunction, if they have a significant drop in their ejection fraction to less than 50% on their current echo, or have had a drop of over 10 points and that EF is less than 50%. If they have new focal wall motion abnormality, or if they've been found to have moderate or severe aortic, mitral, or significant severe tricuspid disease or severe pulmonic valve disease. These are the certain algorithms that we've deemed as clinically important to maybe be considered to be seen by a cardiologist or specifically a cardio-onc team if need be. So again, this is kind of how Tempus Next can help identify patients by using that abnormal algorithm on the echoes, and then it sends an electronic notification in the message system in our EMR. It says, your patient has been identified as having an abnormality according to the current guidelines set forth by the ESC and ICOS. Consider a referral, and it gives specific information about how you would make an appropriate referral. The nice thing is, again, some of the patients may have already established a long-standing relationship with a cardiologist here. So the nice thing is it won't send unnecessary messages to our oncology colleagues. So again, we're trying to also be cognizant and mindful of over messaging or too much message fatigue for our health professionals as well. So currently we did sort of a soft rollout of this project recently, and this was from January to the end of March of this year, and looked at all echoes that were ordered by oncologists or patients being treated for oncologic disease. And it ended up screening over 11,000 echoes. It ended up being individually around a little shy of 10,000 patients. Of those, we saw that 357 patient echoes were flagged as having an abnormality that was detected by our algorithm. That ended up being 297 unique patients. Average age was 62, 51% were male, the others were females. Of those notifications, we did see, we did sort of, again, like sort of a soft rollout to make sure we were sending the appropriate notifications. They sent out 51 notifications, which would mean about 10% of the patients that were flagged. And when we sent out those notifications, it led to about 10 referrals, which was great. So this is helping our providers realize there is a change or an abnormality that is thought to be clinically significant in our oncology patients. What we did realize until the algorithm got released is that, they were flagging inpatient echoes as well. And so we decided to turn off that inpatient notification because, as we know, if a patient is hospitalized and they're an oncology patient, they might get several serial echoes. It might be sepsis or other things that are playing a role of why they might develop an acute echo change. So we realized that wasn't really very valuable because those patients are, their problems are being addressed appropriately on the inpatient side. When we looked at our data, what was the most common reasons for echoes being flagged was the significant change in LVEF, which is what we're really glad to find and want patients and providers to realize that so that we can get appropriate referrals. Other than that, did see some significant wall motion abnormality. 29 had hypokinesis. We did see some changes in RV size, some signs of pulmonary hypertension, a few with pericardial effusions. But as we noticed, the biggest notification was for significant change in LVEF. So our reaction to the results, as I said, we found out a number of these echoes were inpatient echoes. So we actually turned that feature off. So we will only be getting outpatient echoes results that are flagged. We added an e-consult as a source of referral because sometimes still the oncologist may say, hey, I really, before I burden this patient with coming to the clinic to see the cardio-onc clinic, I want to make sure it's an appropriate referral, make sure this is the right thing to do. So we added e-consult referral as a sort of pop-off valve for these patients. We did also see that some of these are in our unique system. We have a dedicated pulmonary hypertension group. We did see that some of the patients who had elevated PA pressures or significant signs of pulmonary hypertension were being referred to our PH clinic, which is the right thing to do. And the next thing is that we're pushing for real-time notification, so there's not a lag time in these notifications being sent out. And really, our next steps are really to make sure these notifications are getting to our oncology team to re-engage them to say, how is this going? What's the feedback? Again, we had some preliminary meetings with our whole oncology faculty at one of their faculty meetings to make sure we are not pushing something out that would be a burden to them in this world where we're sensitive to, fatigue from too many notifications. But yeah, we're really excited about this ongoing project, and we'll continue to get feedback and look at our results, and hopefully look forward to publishing this in the future. But this could not be done without our huge, wonderful team. I want to really thank Dr. Effie Andricopola. She's been spearheading this with Dr. Julian Booker here at UAB, with Chris Rogers, who part of Tempest, who's been a wonderful help on helping us tweak our algorithm or helping us to rethink different things. Our other colleagues here, Dr. Reem Howie, Garima Aurora, my team, Courtney Estes, my nurses, Abby Johnson and Alexandra Schneider. We really could not do this without our whole team to help us. And of course, to our oncology colleagues here at UAB, it is a pleasure to work with every day.
Harry, thank you so much for the great work you're doing, and thank you for taking the time to share it with us, with our community. And I'm sure that you'll be hearing from a number of folks with further questions and more information as this develops. We'll look forward to an update as well going forward.
Great. Thanks so much. Thank you, Stephen. Appreciate it.
Thank you.
Thank you.